Okay, so we're live on YouTube now as well. So yeah, good to start.
Great. Good evening. Thank you for joining us tonight. It's great that there's, let's have a look. There's 175 of us and counting. We had 200 last week for the first webinar, and we've had about 1,000 views of that video on YouTube subsequently. So that's been super exciting. Just for those of you who aren't familiar with the website, it's www.orthohub.xyz. It's a free interactive orthopedic education. We're never going to charge for it. It's just to share good practice and good content. Just out of interest, it's where Pete Bates and I host the C1 Do 1 podcast. We have quite a few case discussions and short 2-minute video clips of Pete out and about in random locations. And we aim to continue hosting regular live interactive webinars. Please do follow us on social media and get involved. The Twitter handle in particular is @orthohubxyz. So I just want to start by laying out some ground rules. The aim of tonight is basically to update you all on the latest in orthopedic education and training and the impact of COVID on this. It's been an unbelievably fast-moving area recently, and things are still developing all the time. So we may not have all the answers, or we may not be in a position to share all the answers tonight. But what we will do is we'll ensure that any new information or any relevant links that come out subsequent to this webinar are highlighted to you as soon as possible. I think the last thing to remember is just the fact that we are in the middle of a pandemic. It's impacted everything. It's a crisis the likes of which we've never seen before. And I know that the SAC, with Rob Gregory as chair, all the TPDs, BOA, BOTA have all strongly been fighting our corner and robustly representing us all. So let's just bear that in mind. I want to thank all our speakers for making the time to join us. I think it's a really excellent way of addressing trainee and trainer concerns and being visible and available in these unprecedented times. It's understandable that when people experience such drastic changes as we've all undergone in the last month or so, coupled with possible redeployment away from your normal areas of practice, maybe a loss of identity and certain uncertainty about the future, then it's quite understandable there'll be heightened emotions and stress. That's quite normal. I also, do understand that in some parts of the country, you may not have seen the same severity or mortality from COVID as we've seen in London and the other regions. And you may wonder, well, why has this impacted everything so significantly? So I ask you all to please show respect for each other tonight so that we can make this webinar as productive and valuable as possible. The format for tonight will be that we're going to work through all aspects of orthopedic training chronologically. And each section we'll aim to answer the questions that were submitted to BOTA as part of a roundtable discussion. We have Tricia Campbell as BOTA president, got Rob Gregory, who's the SAC chair, and Lisa Hadfield-Law, who I'm sure you all know, as the BOA Education advisor. The one thing I want to say is that there is a Q&A box, and you can submit any new questions that arise via the Q&A box, but we're only going to be responding to those questions that are applicable to everyone. If it's one of those, I'm a left-handed ST6 with a peanut allergy and my wife's mother's gerbil type questions, we won't address those. And those kind of highly personal issues are really best addressed locally with your AES and your TPD. So I'm going to hand over to Mr. Rob Gregory. He's the SAC chair. Rob's been working tirelessly on our behalf.
He needs to tilt the screen down a little bit, doesn't he? That light is just...
Hi, Pete, can you stop talking? Since Mark Crowley took over about 2 months ago, and for Rob, who's taken over, talk about a baptism of fire. So over to you, Rob.
Thank you for hosting this tonight, Cash. It's a good opportunity, I think, to clarify a wide range of issues that are clearly posing difficulties for a lot of people. What I want to do first is just to run through a few slides that I hope will give some context to where we are and why we are where we are. And I want to look at how we can influence the changes that are necessary due to the impact of COVID-19. There are 4 bodies that I want you to look at. First of all, briefly on the top, we've got the BOA, we've got the SAC. You'll all be familiar, I hope, with the SAC and what it does. And we've got BOTA. But on the bottom, I've ringed the 4 nation statutory education bodies that include in England Health Education England. Now, the relationship between those groups is complex, and from the perspective of recruitment, for example, we've got On the left, the selection design group, which is an orthopaedic group that is appointed by HEE. They've got the medical and dental recruitment and selection group on the right, which is accountable to the 4 nation statutory education bodies. Now, the relationship between all these is complex. The key lines that I want you to look at here, the arrows, are the ones in yellow, because they represent the input that we can have towards the decision-making process of the 4 nation statutory education bodies. And those yellow lines represent advice that's given. So the SAC, the Specialty Advisory Committee, is advisory to, the clues in the name, obviously, it's advisory to JCST, who in turn are advisory to the 4 nations statutory education bodies. Similarly, the advice that the selection design group give to HEE and the other statutory education bodies is only advisory. So the decision making is all the role of the statutory education bodies, and it isn't the BOA, it isn't the SAC, and it isn't BOTA. What we hope is that the advice that we give will be listened to and accepted and implemented, and in many cases that is what happens, but it isn't always the case. And I think perhaps later on this evening there are times when we need to bear that in mind. I'd like to secondly just share the principles that we've used of managing training and the changes that are applicable during the COVID-19 crisis. And the number one principle is that whatever we do has to be safe for patients. We can't afford to have a drop in standards, and that is an absolute. Having said that, we need to follow the second important principle of being fair to you as trainees. And what that means is that we have to apply discretion appropriately. Now, we normally apply discretion, but I think there's never been a time when it's more relevant at the moment, and I'll explain where that can be applied later on. This second way we can be fair to you is by having a rapid dissemination of accurate information wherever possible. And we've tried to do that, but I hope that you'll understand that sometimes it isn't possible to rapidly disseminate information because there's a fear that and a concern that may not be accurate information that's being disseminated. So if there seems to be a delay, try and understand that it isn't something that we want, but is something that is really enforced by the system as a whole. And finally, we're mindful that we need to prioritize the critical training periods in particular. That is transition to ST3, transition across ST6 to ST7, and transition from ST8 to CCT. So in summary, I think the overriding principle in terms of training progression is that it's the destination that's more important than the route. The destination is fixed, and we're not prepared to accept any drop in standards for that day one consultant that goes onto the specialist register. But how you get there, we're very much mindful that there are a variety of routes, and that variety will be greater at the moment than it has been previously, but ultimately our aim is to get all you trainees to that final destination of CCT. That's my introduction. I think I'll pass back to Kash now, who I think is going to start to deal with some of the questions maybe to get us on the way.
Great, thanks, Rob. So we're going to work our way chronologically through training from the entry point out to the exit point. So we'll just start with national selection. National selection has obviously been changed completely because of this unprecedented crisis. And there were quite a few questions that came through about scoring. I wonder if those questions have changed, because obviously there's some data and results have been released this morning. Trish, do you want to just let us know about some of the BOTA questions that you received?
Yeah, sure. So the first question, again about scoring, is how was the appointability score of 21 determined?
Okay, Rob, do you want to take that one?
Yeah, I will. I'd like to give some background to selection, because again, I think you need to know the context here. If I can get my screen up, if I can do that, that's great.
Just go, Rob does it with Mark Crowley. And the thing that's interesting about that is that a lot of the data has been collected and analyzed with Giles Patterson in real detail. And we've got a really good idea of numbers and how your self-scoring will correlate with the actual final score.
So yeah, let me just remind everybody of the principles of selection prior to 2020. These are the same principles that have applied for 6 or 7 years at least. I've been on the selection design group for that length of time. That group's now chaired by Mark Crowley, who's put a lot of work into this. So prior to 2020, there was no shortlisting. There were 5 assessment stations that included portfolio, and the self-assessment score was part of the portfolio station. So the self-assessment score represented about 10% of the total score previously. So it's quite a small component. I'll come on to that later again. So we assessed 11 domains, including, for example, technical skills and situational awareness. And you'll see from the pie chart on the right that the majority of the assessment related to non-technical skills. So the assessment process isn't a replication of the MRCS, it's something quite different. Having assessed all the applicants, they are then ranked in order, and that ranking allows trainees to be given some degree of priority according to their ranking in terms of where they want, which program they want to join. We've also got a threshold appointability score. Now that is a score that is based on safety. Below that threshold score, we have concerns about whether the appointments are safe, and that is something that has been tested in the court of law a few years ago. And the way that threshold is applied has been deemed appropriate. If we go on to the principles of selection this year, they're quite different, and they're quite different simply because of COVID-19 and the fact that we can't run the traditional national selection with the 5 stations, etc., as I've described previously. The decision about how to proceed this year has been made by HEE. We advised something that was different. We didn't want national selection this year. We felt that a system that allowed appointment to LATs would have a lot of advantages. But HEE wanted, and I think I can understand their position completely. They want some consistency across the whole of selection to all the medical and surgical specialties. And so what we're left with is a system that appointed to NTNs. There was no shortlisting, and it was decided that the self-assessment score should be used alone without validation. We were then posed with a question in the selection design group that particularly Mark and myself had to deal with about how do we decide the threshold appointability score. And we came to this by looking at historical data and comparing the last year, in particular, the overall score with the self-assessment score. And we set the threshold appointability score at a point where we felt that the risk of appointing somebody this year that wouldn't have been appointed last year was very low. And had we lowered the threshold appointability score further, the risk of appointing applicants who wouldn't have been appointed last year would have been greater. Now, we acknowledge that by having that assessment score, ultimately we came to 21, we'd have a system that was safe, but we also acknowledge that it potentially may deprive good potential trainees of an appointment this year. But we took the view that our priority has to be safety. The next question is it fair? And this is a question that we've only partially been able to answer. The data is available from previous years, and in particular from last year, that correlates the assessment score, the overall assessment score and the self-assessment score with demographic groups. And we'd hoped to be able to demonstrate that there were no demographic groups where there was a bias in selection, and that we weren't able to get hold of the majority of that data. However, we have been able to obtain data that shows that there's no gender bias, and we're very comfortable with that. So we can say, in terms of fairness, we've got the evidence to show that it's partially fair, but we don't have the evidence that may exist that shows that it's more completely fair when looking at all the demographic groups that that go into the appointment process. So the next question is, what about question ranking? We have to rank everybody, even if there are unfilled posts. We still have to have a ranking so that we can allocate, according to that ranking, successful applicants to the program of their first selection. And the ranking system that we used this year was to prioritize the clinical questions. The ranking didn't prioritize any score that was influenced by the length of experience. And I'm aware that this is quite a controversial subject, the way that length of experience influences the self-assessment score. When you've got a self-assessment score only contributes 10% of the overall score, you've got a relatively minor role of any scores that are influenced by the length of experience. But the role of the length of experience is amplified if you only use the self-assessment score. And we are highly aware of this. And it's for that reason that we've used those, when we've been ranking, we've used the scores that are influenced by the length of experience right at the bottom of that ranking list. And it's not just a question of the reason that we use length of experience as a denominator is that what we're interested in is not the applicant that's got a lot of audits or publications. We're interested in the applicant that's got a better rate of accumulation of those academic outputs. And I think when you understand that, you'll perhaps appreciate that the system that we've got is one that is fairest to everybody. It's fair to the junior trainee that hasn't had the time to publish a lot. And it's also fair to the senior trainee that's been able to publish at a relatively high rate. That's the background to the reason why we use that denominator. And I hope you'll understand that we've tried to minimize the effect of that when we've designed our question ranking. So that's the background to the selection. So, and hopefully I've answered the question about how did we fixed 21 as being the cutoff.
Yeah, thank you. You answered several of the questions that we had there. Thank you. Are you ready for another one?
Yeah.
Yeah, I mean, we can move on to ISCP if you like. I suspect we
I
won't.
think there's a couple of
I don't think I'll be allowed to, will I? So I
yeah,
think,
I think there's a couple of questions that I wouldn't be
what I
forgiven
would
if I didn't
say.
ask.
Would you like me to say something about today?
Yeah, please do.
That's the next bit of next
I
question.
I suspect that's what a lot of people are interested in.
Worried.
This, I was aware of that the outcome of the selection process was going to be published at 12 o'clock, and at about 10 past 12, I realized what was happening. I was in the middle of a virtual BOA council meeting when the WhatsApp on my phone just went wild. When we designed the process, we knew that there would be about 120 posts.
Yeah.
That would be, they're the posts that have been declared by the programs across the country. We knew that they would be several ST8 trainees that are going to want to stay in training for one reason or another. And we tried to get the cutoff score to, as well as being safe, as I've described previously, but a cutoff score that would fill safely 100, slightly over 100 posts.
Yeah.
So, and that was a calculation based on last year's historical evidence. What happened today was that there were 15 posts that were allocated, and so there were 51 applicants were told that they'd been successful, and the rest were told that they'd been unsuccessful. Now that started to ring a lot of alarm bells. Not least, I think, because of the trainees the applicants that realized that their calculation of their score wasn't the same as the calculated score that they were told was applicable to them. And that was highlighted to HEE, who then reviewed the whole process of the way that the scores were dealt with, and identified that there was a very small but significant error for a small cohort of applicants. And what that means is that the whole process has had to be revised and recalculated. I was hoping that the results of that might be available today, but I think it'll probably be tomorrow.
Okay.
Now, what I can say to reassure the applicants that were told today that they were successful is that this error that's been identified won't affect you, but there will be a number of trainees that will tomorrow be told that they have been successful. I suspect many of you, if you're watching this, will know that this applies to you, and you'll be knowing what's going to happen tomorrow because you're all pretty smart and the maths isn't that difficult. But that's the background to what happened today, which was just awful. And we are all incredibly sympathetic to everybody that's been affected today. It shouldn't have happened, but it has happened. But we'll try to soften it as much as possible. But I know that is going to be scant consolation to many of you.
Yeah, I think it's a difficult situation all round. One last question. What will happen next year? So will those trainees who've now had more years post-graduation, will they be disadvantaged in any way when they come to apply again next year?
Well, I suspect there'll be other reasons as well that will need to be taken into consideration when next year's selection process is designed. Under normal circumstances, we'd have a wash-up meeting in June or July.
Yeah.
We'd look at the data, we'd analyze it, and we'd make some initial plans about how we may want to change it next year. And then in November and December, there are normally 2 meetings that are held that design the process for next year. And I'm sure that's what, it'll probably be virtual this year, but that I'm sure is what will happen. And factors like this will be taken into account to ensure that the process next year is as safe and fair as possible.
Good.
And I think, if I can just say one other thing, I'm not sure if everyone understands how much work goes into the design process for the selection. There's a group of about 15 trainers and including four representatives from BOTA, that, including the time that's spent in Leeds, will dedicate 9 or 10 days of the year solely to the process of selection. And the questions that seem like minutiae are considered in great detail often for several hours. This is a process that is taken phenomenally seriously by people that are hugely knowledgeable about training and about the recruitment process.
And I can certainly vouch for that from my time on the selection design group. Rob, can I ask one question? From the Q&A, there's a couple of questions. One has come through that there's someone who's a CT2 equivalent at the moment who's going to apply next year. And obviously having MRCS is kind of a key eligibility criteria, but exam centers have been cancelled. So they want to know, will MRCS still be eligibility criteria for ST3 application next year? I'm assuming that it still would be.
Next year it will be. You have to get to be eligible for a CT3 application. You have to have got membership. Now, if for when you're, I mean, slight speculation here, but when next year, if the sole reason that you can't get an outcome an outcome 6 at the end of core training is because of COVID, and that the one thing you're missing is the membership, then there's the potential, if you are successful in that national selection, to be taken on as ST3, but with the proviso that one thing that you're missing has to be made up during that first year in high surgical training.
And I also appreciate that no one has any idea how long the COVID situation, the lockdown will go on, and how long mass meetings and exam sittings will be cancelled. And so I appreciate that's very much in flux, and that'll be discussed, I'm sure, in great detail at the next selection design group meeting. There's one more question coming from Neil Kang in Cambridge, which is interesting. I don't know the answer. He said that with national selection, you've shown quite clearly from the stats that there's no gender bias. He was just wondering if it's ever been assessed for BAME candidates.
Yes, it has. I mean, we look at this every year, and we look at ethnicity. We look at ethnic group according to graduation. So this has gone into in a lot of detail. We normally see this at the end of each year in the wash-up process, but we don't always have the data in a form that we can keep. But we happen to have it for gender, and we really wanted it for other demographics, including BAME, because if that data shows that there is no bias, it's really important that this is out there for everybody to know.
No, that's very useful to know. And certainly I know the stats are done for each year of training, how many years post-graduation, where they are. So I can vouch for it as being a very robust system. So we'll move on from national selection now. The next thing that I think Tricia and Lisa may be in a position to speak to is the role of what do you do with your placements, ICP, WBAs, and critical CBDs. And for those of you who've not had a chance, Tricia has done a podcast with the PDPods with the Pranay Badev, and she's actually answered this really well. So Trish, I'll let you have another stab at it.
Yeah, sure. So I'll start off with placements. I know this is causing people a lot of concern. I think the first thing to point out is a lot of regional variation. So I know that some places have rotated in April, whereas others rotate in August. So with regards to IRCP, I think it's really important just to keep engaging with it and to document your placements. So even if you move to a different placement, which may or may not be orthopaedics, I think you need to document it so we can look back and see where you've been and what you've been doing. With regards to supervisors, you need to have your AES and a clinical supervisor. you can add as many clinical supervisors as you want. And I think the more you add, the better, because in these times, we're going to be interacting with a lot of different consultants. So the more clinical supervisors you can have, but keep your one AES. That's what I'd say with regards to placements. Lisa, did you want to talk about WBAs?
Yes, I will. About placements, there's quite a good drop-down box on your dashboards as trainees. So there's a few options there to for you to look at that will mean that you get the most out, particularly of your portfolio. I feel slightly uncomfortable even talking about getting your portfolio sorted now, but I also am aware that there is great variation. Some trainees have been redeployed and are on their knees. Others have not got that much to do. And so this might be a good time to get portfolios sorted out and to find your gaps. For those who have been redeployed, having looked today at the generic professional capabilities that will be a focus of the new curriculum whenever it comes in, there are some amazing easy wins there. I've had a look at it. I've pulled out some of the elements that may be difficult to get as part of normal T&O training. But for some of you who've been redeployed and are doing different things, there are great ways of getting some of those. The multi-professional team working, the resilience, the working under pressure, the being a follower and letting others lead, the infection control stuff. There are some quick wins there. And if anyone's interested, I've pulled out the things from the generic professional capabilities and just put them in a sheet so you can have a review of those. In terms of work-based assessments, for those who have not got the time to go looking for holes in their portfolio and filling those, I would urge you to keep a COVID diary. And lots of people are doing that. Niall Eames, who is known to many of you, a spine surgeon in Belfast, he's keeping a diary. Lots of you are keeping diaries. And even if you just capture some of those experiences you may think are going to be important, you can analyse later why those are important and why they might be valuable to your future role as a T&O surgeon. If you haven't time, just keep that diary, whether you do a video diary at the end of the day or make a few notes in your phone or put it on in a book. Just keep a hold of it because it's so hard to stop those leaking out. In terms of work-based assessments, I think the reflective CBDs are going to be incredibly valuable. And again, thinking about just getting to the end of the day, what have I done that is really, really important and really significant? Writing a little bit about that, not war and peace in terms of quantity or quality, just a few notes and then get them validated. And in terms of validation, your educational supervisor, maybe clinical supervisors who are not able to be at work at the moment. A lot of those I know are very happy to validate. And maybe even most valuably will be those that are outside T&O completely. Nurses, anaesthetists, pharmacists, physicians, because anybody you can appoint as a clinical supervisor. If you are not a surgeon, you just go to register on ARCP and press the button that comes up that says you want to go in as an assessor. It takes about 3 minutes to register, and then anybody can validate your case-based discussions. And I would think broadly, not just cases, but entire shifts, significant events, webinars like this, capturing what you've learned from these webinars, whether they're these ones or your regional ones, can be really valuable. And the critical CBDs are being set up all over the place. The PD pods, I think what the session you did, Trish, I think you talked about setting up critical conditions.
Yeah, so Pranay Budev, the consultant who I did the podcast with, he's offered to do the pediatrics critical CBDs with people. They can just get in touch with him via the website. And I think I'd encourage trainees to make the most of the opportunities, because there may actually be a bit of downtime when you can do a critical CBD and get that's one box ticked.
We're going to, with the AO Trauma, AO UK are going to set up critical conditions for some of the trauma CBDs, and then maybe some of the spine ones as well. But a lot of those are being set up regionally. I've been really impressed with the regional programs and how regions have absolutely turned around some of these very different ways of learning and capturing what's been learned.
Thank you.
Yeah.
Just with my TPD hat on, what I would say is that numbers are not the key here. As we've said, take every opportunity you can get to do WBAs. If there are trauma lists, that's fine. But if you have TNO completely, the fact is that there is, just have a look at where you can meet generic curriculum requirements like leadership skills, non-technical skills, team working. You may be teaching junior staff in other specialties or EMPs in minors. You know, and the thing is, as Lisa said, that the key thing is reflection. Reflection is the thing I find isn't, a lot of people don't necessarily engage with it. And I think as a TPD at ARCP, I find it really quite useful. And particularly here, when you may not be able to do DOPS and various other things, that's a really great time to do it.
Yeah.
I would make sure that you reference COVID-19, because there will come a time when you might be an ST3, and when you're, by the time you're an ST8, 5 years, we may have even forgotten all about it. And they'll be like, what happened there? Why is this? And so it's important. And the one thing I would say is that come ARCP and someone has no cases in the logbook for this period, of course, that's fine. But the fact is, the people, I would urge you to keep engaging with ICP. The people who run into trouble at ARCP will those who ignore it. And I would say ignore ICP at your peril. Keep engaging with it, uploading bits of information and evidence where you can, accepting that it may not be orthopedic. There's still a lot of good stuff to do. And the last thing I just want to say on this is that I think it's a great opportunity to get off the clinical treadmill, perhaps. And for some reason, you know, people, it's an on-call, it's a list, it's a clinic, it's an on-call, and it doesn't stop. For some people, it's a great opportunity to plan ahead and just focus on kind of what do you think are the easy wins in your portfolio. If you've got, everyone's got papers. Every single person here has got a paper that they, an audit they haven't finished, or a paper that they started writing up they haven't finished. I would urge you that if you have the opportunity now, do it. Of course, if you're redeployed, that may be challenging, but I still think there's an opportunity, and it's just a chance to get ready for when the tap turns on after this, which we'll come back to later. There's going to be a deluge of cases. Trish, is there anything else you'd like to add to that?
No, that's it. I don't know if there are any questions in the Q&A box, but there are a couple of questions that have come through beforehand, kind of with regards to rotations rather than placements. So I've got a trainee here asking, what will happen at the time of the next rotation change? Because I know that some people have changed in April, were meant to change in April and haven't. And the question is, will trainees be rotating in August? So
in my rotation, for instance, I think it's pretty similar to most TPDs in the country. We have an April-October swap rather than, you know, some people have August.
Yeah.
But the thing is, everyone was kept in the same place on the basis that, let's just say you were due to go into a peds job next, or a spine job, and there's no spine happening. And then in October, you've got to move on somewhere else. And then you'll be like, well, hold on, I haven't actually got any spine experience. People say, well, you've done your spine slot. Someone else wants it now. So for that very reason, our plan, I think the plan for most people, is that you'll stay exactly where you are with the same people in a safe place, in an institution environment that you know it. And then you will rotate in October to the jobs that you were due to have rotated to in April. Yeah, that's a safe and logical approach. And the other question is...
Can I just come in there?
Yes.
Just to make a point, the decision not to change in April was HEE's, and that was based on safety issues. And I think, although there was a lot of angst about it at the time, I think that was absolutely the right decision. What will happen in August may still be, well, it will be dictated by HEE, but that again will depend on the situation relating to COVID as it applies in August. But what I've advised TPDs at the moment is to assume that there will be a change, and that there'll be a rotation in August or a rotation in October if it's applicable to your program. Because it's far easier to move from a situation where you're expecting to change to one where you don't change. What I'd like to just emphasize to the trainees that may be changing in August or in October, is that the management of that change by the TPDs is going to be really difficult, because the demands of each of you as trainees are going to be different and are going to be greater than they normally are at a rotation. Your TPDs are a fantastic group of people that have really got your interests at heart, and they will do everything that they can, I'm sure, to give you all the next post that you want and is best for you. But it may just not be possible for everybody to get the absolute perfect post. And I think please bear that in mind, and don't give your TPDs grief, please, if you think you haven't quite got what you want. Try and look at the rotation management from their perspective. And I think that will apply more to junior trainees, because I would expect slightly more priority to be given to placements for senior trainees who will have less time to play around with before CCT.
Yeah.
Okay, great, thank you. Should we move on?
Yeah, I've just got one last question with regards to placements.
Sure.
So one trainee has asked, does this current placement count towards training? If we haven't achieved what we set out to achieve, will we be able to repeat the placement?
Okay, well, I think that feeds in quite nicely to the next slide.
Yeah.
After you, Rob, this is your area of expertise.
If I can come onto my my screen.
Sure.
There we go.
I mean, it's for this very reason, Trish, that question that the outcome 10 has been brought in. I still think they missed a trick. I would have called it outcome 19.
Yeah.
Let's see if we can. Yeah, this was really the slide that was going to go with the last conversation. It will not be easy for TPDs at the next changeover, but I won't labour that again. Let me explain a bit about the background to ARCP and COVID-19. And again, I've got to mention this with a health warning that the finalised version of this will probably not emerge from HE for another couple of weeks. So everything that I say, I've got to tell you with that little caveat, but I'm not going to say anything that I don't think is likely to apply eventually. So the changes aren't yet finalised, but we're waiting for feedback from the 4 nations. The principles that we're using in the way that we're adjusting ARCPs because of the impact of COVID-19 is firstly that the ARCP should proceed if possible, but we know that it may not be possible in every case. But if it is possible, the training periods that are critical, i.e. at CT2, ST6 and ST8 are the ones that are going to be prioritised, and you have to have an ARCP at those stages in order to progress. There'll also, as always is the case, there'll be priority given to trainees that are on adverse outcomes. And the principles that we're using to be safe, you have to have an outcome 1 for a critical period progression. So you can't progress to CCT on anything other than outcome 1. And to be fair, there's been the introduction of the new outcome 10. And the idea of that is it takes into account loss of training opportunities due to COVID-19. It's not loss of training opportunities for any other reason. It's solely related to COVID-19. And again, this is where I'm trying to encourage as much discretion as possible, where it's sensible and pragmatic, and I'm sure that will be applied. A couple of things that we've asked for specifically is one, and again, this hasn't been clarified yet, but hopefully it will be in the next couple of weeks, is that there should be a no-fault training extension. How you actually get the training extension isn't clear, but you won't, if you get an outcome 10 at your next ARCP, that won't be accompanied by a training extension unless you're at a critical transition phase. So if you're having your ST8 ARCP and you haven't achieved all your goals because of COVID, you will be given both an outcome 10 and a training extension at that time. But if you're not at a critical stage, you'll just be given an outcome 10. What that will stimulate then is a PDP that you'll agree with your program director that will run until your next ARCP. And then if you've met that PDP, you'll be given an outcome 1. If you haven't been given, if you haven't achieved that, the goals in that PDP, then you won't be given, unless we can use discretion. If there are major deficiencies, you can't then, as things stand, progress to another outcome 10 because we don't, that the issue of a repeat outcome 10 hasn't been decided. What may happen though, is that if it's decided that you need an extension of training to meet requirements that you've missed because of COVID, you will probably get an outcome 1 with an adjustment of your CCT. So that's what I would call a no-fault training extension. So you don't, there's no adverse outcome, there's no 2 or 3, you get a 1 plus an extension. Now, when that next ARCP can take place hasn't been decided. The inference from the initial draft document that we've got is that that'll be after a year. But I'd like it to be less than a year in some cases. If you think that you can catch up within 6 months, I'd like your ARCP, the next one, to be after 6 months. And that gives you the opportunity to get back onto an outcome 1 and have no loss of training. So your CCT date would remain as it is at the moment. So that's something that I've asked for, and we'll see what happens. And the other thing is that wherever possible, all these decisions are made quickly. And I can appreciate why sometimes they can't, but at every opportunity, I think we have to stress that you as trainees need answers to these questions relatively soon, not at some distant time in the future. I'm mindful that the whole, the concept of the ARCP changes as it's written down is quite difficult to grasp, and I've tried to diagramize this, and I'm going to show you a few quick examples of what might happen to a trainee who is on an outcome 1, who isn't at a critical change period, particularly isn't at ST8. And the diagrams are going to have some colors in, and the blue lines represent normal training and the yellow lines represent COVID training. The red dots represent areas of deficiency in training, and the bigger the dot, the greater the deficiency. So we've got an ARCP. Let's say this is at a trainee at ST4, he's on an outcome 1, has 12 months where everything is smooth and they get another outcome 1. That's as it is at the moment. The next 2 examples are trainees that have no training period that's under the influence of COVID-19. So with a small area of deficiency, for someone that isn't at a critical phase of their training, I'd expect discretion to be shown in an outcome 1. But if there's a major deficiency, as is the case at the moment, I'd expect an outcome 2 or an outcome 3. I don't think that's particularly controversial. That's what happens at the moment. Or there may be perhaps slightly more discretion with that second case. If we look at 4 more examples where training is affected by COVID-19, and let's just say that we've got 3 months of training that's affected because you're not on an orthopaedic ward, you've been redeployed. The 4th case down there is similar to the first one in a way, because there's no training deficiency that's resulted from the period outside of orthopaedics in an area of redeployment. So we'd expect that to be an outcome 1. The next one down is the trainee that really spends most of his time on a non-orthopaedic ward and has very little chance to maintain the trajectory of training that he or she was on before. So that's the primary example of someone that would be given an outcome 10. If that deficiency is relatively small, I'd expect discretion to be shown and an outcome 1. And the last example, again, where the training deficiency isn't influenced by COVID-19, I'd expect an outcome 2 or 3. And we can do this sort of diagrammatic play with other situations. I've got other slides that I won't show because it would take too long, but I think for a lot of people, it might be easy to grasp where we're going with outcome 10 in particular and what the options are that we've got at the next ARCP. And I think to reassure people, I would expect most trainees at the next ARCP to get an outcome 1. And there's been a lot of talk about blanket restrictions in training progression, but this just isn't true. I think most of you that are training at the moment will end up getting your CCT at the date that is in your portfolio at the moment. So that's sort of my summary of where we are with ARCP. If anyone, any questions relating to that, because I'm aware there's a lot of questions that have been asked that are really good.
I think that diagram is a really clear explanation of the possible options at ARCP, which answers a lot of the questions, but there are some specific ones. Can I ask the specific questions?
Yeah.
So I've had a question here. Doesn't outcome 10 preclude you from sitting the FRCS exam? So for example, a trainee coming to the end of ST6, progressing normally prior to COVID-19, who would normally be eligible for sitting it in November 2020, then went on to get an outcome 10 for this current 6 months. Would they be eligible to sit the FRCS?
If they're starting on an outcome 1, the answer is yes. If they're starting on an outcome 2 or 3, if the PDP that addresses the deficiencies that have led to that adverse outcome, if it can be demonstrated that they have been addressed, but they can't be given an outcome 1 because of COVID-related reasons, that trainee can sit the exam.
Okay, I think that'd be reassuring for a lot of people because we had that
That's been a question that's come up on the Q&A as well, and so I think that's very helpful. Thank you.
Yeah, there's another question that's come up a couple of times with regards to ARCP. So it's to do with how flexible the ARCP will be, because obviously there's a significant impact on elective orthopaedic operating. So trainees probably will not achieve the indicative numbers for some procedures. How strictly will the indicative numbers be enforced at ARCP?
If we go back to what I said originally, it's what we're interested in is the destination, not the route.
Yep.
If the TPD and together with the trainee and the ARCP panel believe that trainee is going to progress to CCT without needing additional time and being able to make up that deficiency in the logbook numbers, I'd expect that trainee to be given an outcome 1. Sure.
So there'll be an element of flexibility.
If it's a COVID-related reason, then that would be a 10. But if it was a 10, then there'd be the opportunity to catch up over the next year.
Yeah, that makes a lot of sense.
But based on your statement there, Rob, of it's the destination, not the journey, which I think is a very valuable thing that everyone needs to bear in mind. Someone's asked on the Q&A, will 1260 procedures still be kept as a hard and fast number for CCT?
So again, going back to what I said before, is that we're not prepared to drop the standards. So we don't want to see trainees progressing to CCT that have met a lower standard than has been traditionally mandatory. But it's always the case that approaching CCT with a good trainee that may have some minor deficiencies, that discretion is shown, and I would expect that to remain the case.
Yeah,
we're not worried about 2 or 3 cases here or there.
No, and similarly, I agree that I think it's the fundamental thing that we keep in mind is that it's all about patient safety, and that the standard does not drop. No trainee now wants to be tarred with a brush of, actually, you were less of a trainee, less of a standard than any of us, 10, 20 years ago, even now. And so I don't think anyone should be looking to lower that barrier, and I'm not sure anyone is. But absolutely, it's important we maintain that quality, we maintain safety, so that when you're a day one consultant, you can look any other consultant in your department in the eye and know that you're equal of them, and they will treat you the same. So thanks for that. The other thing I would say is is that people looking at bare minimum at ST8 do concern me slightly, because the fact is your good trainees are so comfortably over that barrier that even a 3-month non-operating will still get them comfortably over the line. And so that's just something else to bear in mind. I've got one question from Steve Millington, my mate and colleague, who says, if we're implementing outcome 10 and extensions for particularly for ST8, so plan in place, then does that mean and they stay on, does that mean there'll be less training slots available next year at selection?
There won't be next year. There might be. There might be this year. So this is the question about periods of grace, yes, or training extension at ST8 because of outcome 10. And we are expecting a significant number of ST8s to want to remain in the training arena, whether that is post CCT as a part of a period of grace, or whether it's as an outcome 10. And I suspect a lot of the outcome 10s in that situation will relate to the exam.
Yeah.
And this is a calculation that has to be made locally by program directors when they declare the number of posts that they want to fill. And this is a really difficult one at the moment, but this is fed into the process that's happened recently when programs have declared the number of slots that they want to fill. But we've been mindful of the need to look after the ST8 that may not be able to go on their fellowship, for example. And I think it's absolutely right that if possible, they should be given the opportunity to remain in training during a period of grace.
And apologies for perhaps jumping the gun, because I think the fellowship slide's in a couple of slides, but while we're here, it kind of fits together. The one thing I would say is there's so much uncertainty at the moment. So we as TPDs are being asked, how many numbers do you need now? How many will you need if people stay on? And the fact is, I've got chaps going to Canada who are still being told for August, carry on as planned. We may have a medical exemption for you, and we're pushing to do that to get you all across. But the fact is, these things are changing on a day-by-day basis. And so there are certain things we don't have the answer to today, just as I said in my intro, and we're going to have to just stay vigilant. And as soon as we get that data, we'll share it with you.
Can I just go back to ARCP before we move on?
Of course.
Yeah, there was one question, just asking for clarity on how long outcome 10 will be valid for. Will it just be for this 12 months? Or is it something that we don't really know as yet and will depend on how long the COVID situation goes on for? Well,
that's a really good question, and there isn't an answer to that yet. But what I would say is that I've fed into JCST, who asked the same question to HEE, that we have to consider the option of extending the principle of outcome 10 beyond 12 months, because I think the impact on training of COVID is going to last more than a year. So it's logical that an outcome 10 should last for more than a year.
Correct.
But hopefully a couple of weeks we'll know the answer to that.
Thank you.
Thank you. Rob, you wanted just to touch on the new curriculum whilst we were here?
Yeah, the curriculum has been approved finally just a few days ago, which is good news. The next question is, should there be a delay in the implementation of the curriculum? And there are pros and cons to a delay. It was originally planned to be implemented in August of this year. We had designed a quite an extensive program of education relating to the introduction of the curriculum, which is not going to happen now because of COVID. So I think there's a strong argument to delay the introduction based on the fact that it can't be introduced properly. We've been asked to again feed into JCST to see what our views are, and the overwhelming view of the TPDs, because they've been surveyed on this, is that there should be a delay until August 21. I think that's right. I think that will probably be supported by JCST, but I don't know for sure. And I'm also aware that that is the general view of most of the other surgical SAC chairs. So we don't have an answer on that at the moment, but I hope there will be a delay in the implementation, because when it comes in, we want to do it properly.
Yeah, and I think that's certainly the overwhelming feeling within the community. And it's something that we could do another webinar on, or even if we don't, I'm sure there'll be lots of guidance being released at the time.
When we can come up to implementation, this sort of thing would be absolutely fantastic.
Yeah, it'd be great when you can disseminate the information rather than feel like a politician on the stump being, with Laura Koonsberg down there. Actually, she gives them an easy ride. Moving on to regional teaching. So as I said, we set up OrthoHub to be regional teaching for our local rotation, and then it kind of really took off. There are lots of really good practices regionally. There's been some large and small group online teaching. I know the guys in Cambridge, the guys in Mersey, a lot of them are doing some really, I'm sure it's very widespread. Lisa, are there any particular examples of good practice? Because I know you've been dipping in and out of quite a few things. Is there anything that you want to just mention here? Just so for those people who are perhaps not getting any teaching that they might wish to speak to their local trainers about?
Definitely. Looking at some of the initiatives that have been set up, they were set up right at the start. So really early March when people saw this coming. So Mersey have done something every single week and are now at a stage where they're running 4 parallel rooms at once, with one doing peds, small group teaching on peds, others on spines, and they have reached a pretty sophisticated level. So it's all really pretty slick, with moderators, trainers and trainees working together. Feedback from trainees that actually they prefer this virtual regional teaching. They can all get to it. They're not trying to rush back onto shifts in places, and it's much more flexible. I happened upon Neil Kang's this afternoon. I wasn't aware of it, but again, just an excellent initiative and some fantastic engagement. And so there are pockets all over the place. And somebody asked the question, can we access some of this good practice? And I think there's probably some scope for pulling together some of those principles. I know Mersey has written this up already, and it's with, I think the BMJ, it's been submitted to the BMJ, but I'm sure they would be happy to share that with you. But I do think there's some scope for looking at some of the very different, very creative things that are going on.
And, you know, there's never been a time, I mean, there's been a glut of webinars like never before, and some podcasts, and there's all sorts of things going on all over the place now. And so if you're not having any regional teaching, see, the other thing is that different regions have been impacted very differently by COVID. There are some places where the consultants are completely, and the trainees are redeployed or doing a full on. And there's some places where actually you've stopped your elective practice, you're running minors, and you're kind of thinking, what's going on here? And so those are the places you may want to approach someone locally and set up some Zoom teaching. You get a free account up to 40 minutes. You can use some trusts of Microsoft Teams. NHS.net, I believe, has Microsoft Teams now. So there's a whole bunch of stuff that you can do for regional teaching. And without meaning to sound like a plug, we're hosting webinars all the time here. And so there's a whole, you've got more online teaching available to you right now than there's ever been in history. I guess the other thing that people really want to know about, and a thing that a lot of questions have come about, is to do with the exam.
Yes,
obviously there's been a huge challenge on the basis that you can't get patients and people together. Tricia.
Yeah, I've got one here. So due to the cancellation of FRCS part 1, is there likely going to be a backlog causing a delay for those in ST6 who were planning to sit in November?
There'll inevitably be a backlog. It's by definition, as soon as you have a cancelled diet, then you have a backlog, and the question is how you can accommodate that, that backlog. I think the question really is one that we can't answer, but we can start to get moving with the exam again when it's safe to do it. We've got our next section 2 planned for November. We don't know whether that will go ahead. It may not. I'm aware that there are discussions at the moment that are going on with JCIE to deal with possibilities, and there may be news about that coming out over the next week or two. Again, it is something that it is frustrating. Like, I can't give you an up-to-date view, but that is where we are. But we're aware that there's going to be a backlog, and everything will be done to try and deal with that backlog. But the plan at the moment is for the May candidates that can't sit in Aberdeen to be moved to November.
Yeah.
But and it's not just section 2, it's section 1, of course, that needs the driving test centres. So it's largely the social distancing rules that are going to determine what happens with the exam.
Mm-hmm. Yeah, the other question we had, we've already answered, and that was with regards to people having an outcome 10 and sitting the FRCS. So I don't know if there are any questions that have come through now.
I know I've just answered a couple whilst we were chatting, but I think the main thing is, will people who were cancelled and made given priority for the next sitting? The answer is yes. We just don't know when the next sitting will be.
Yeah.
Yeah, no, I think we've dealt with, actually. The nice thing about the discussion is we actually managed to answer all the questions in advance.
Oh, right, okay.
If we move on to, we're almost there, guys. We're not far off. Fellowships and CCT. As I mentioned earlier, I've got some trainees going to Canada, and a couple of them been told, we're not sure what's happening, and then others have been told, get on with it. We're expecting you here on the 1st of August, and we're getting special medical exemptions. So fellowship, but the fact is, we're all TPDs and the SSC are very keen to support anyone at ST8, and so Rob mentioned the period of grace, and you are very welcome to stay on and go on fellowship later. The one thing I would say, is I've said to my trainees, is keep in touch with your fellowship directors, because they will have a cohort of people lined up to come next year to their fellowship. And if they hear nothing from you because you assume it's not happening, you can fall off their radar, and it's very much out of sight, out of mind. But if you keep in touch with them and just keep explaining what the situation is, then the fact is you will get first dibs when the door opens up again. Would anyone else like to add anything to fellowships or CCT?
I've got a few CCT questions, if that's okay.
Yeah, sure.
So I think we've answered some of them already. The first question is, if an ST8 has fulfilled all of the JCSD requirements, will they still be able to CCT and go on fellowship?
Well, yeah, if you get an outcome 6, you'll get your CCT, and then you can go on your fellowship, provided that the rules allow you to travel, if it's a fellowship abroad. Yeah.
The next question, would I be able to request my CCT date to be officially extended by 6 months rather than take a period of grace?
It depends on the reason for having the training extension. The only way you can get a training extension at ST8 is with an outcome 3 or with an outcome 10. So you need to think about that.
So this person said that they were going to go to do spines the second half of ST7 and ST8, but obviously if they get redeployed to medicine, they're going to have less time doing spines.
Well, the question there is, what is enough time doing spines to get an outcome 6 and get onto the specialist register? And I think TPDs will be sympathetic to a degree, but they have to look after the whole program, and it may be that doing only spine after the middle of ST7 7 isn't the thing that can be delivered. I'm sure that all TPDs would try, but it may not always be possible.
Yeah.
Rob, there's a question coming for you from Jane Webber. So Jane has said that the major difficulty for all trainees that she sees will be the ability to meet operative numbers and indicative numbers, and it's unlikely that anyone can double their numbers to make up for the 6 months over the next kind of 6 to 12 months post-COVID. And so the question was to do with giving people extra time as they approach CCT. She's asking, will these trainees require later outcome 3, or can extra time be given at that later stage without an outcome 3?
So when I've raised the question about what happens after 12 months, this is the example that I've used. It's the trainee who would normally be expected to get 300 cases in a year, but actually gets 150. So to catch up the following year would need 450, and 450 in a year is pretty tough. That's hard. That's a hell of a rate of acquisition of logbook cases. So that's it. For a trainee that is middle years perhaps or junior, ultimately that should be caught up. And I think that trainee should be allowed to catch up without having an adverse outcome. So I don't think that should be an outcome 3. At the moment, it looks like it may be an outcome 1 with a training extension with an adjustment to the CCT date. So in other words, that's the no fault extension that I talked about earlier. But that Jane's picked up she's obviously on the same wavelength, because that was the one thing that worried me about, or was the best example about why COVID might affect a trainee for more than a year.
Thank you. The other thing that I just wanted to say was that we don't know how long COVID is going to go on for and how long normal practice will be stopped. But even in London, you know, so I'm at Barts, we've got Nightingale is part of our trust. And we've been hit pretty hard along with lots of other places. But the fact is already now we're having discussions about when can we reopen elective. And all of a sudden we've kind of gone from a very emergency CPOD list to getting all our trauma lists back as normal, you know, 3 lists starting tomorrow. And already there are talks to restart elective operating. So the major hit may not be as significant and prolonged as people had thought. So there's some hope there. There's just one last thing whilst we're on fellowships in the CCT. So Zach Silk, who's one of the POT trainees in London, has just said he's post-CCT fellowship, and there's this slight concern that the guys who are out of training who are post-CCT but haven't got a job can fall in the hole. And he's saying that, and the fact is everyone needs a fellowship to get a consultant post, unofficially, but many people will feel extremely unnerved about the impact of COVID-19 on their training and what it will have on them securing a consultant post. And that people can feel a bit isolated. He says, what can you recommend to post-CCT fellows? What can they do to maintain their skills and appointability? And Lisa may want to come in on this one as well.
Yeah, this is one of the options would be a period of grace, which is one of the reasons. I guess that's not quite the question that's being asked, but certainly someone approaching that situation that can't do a post-CCT fellowship may want to think about a period of grace, and that has been accommodated to some extent when we've calculated the number of appointments that we want this time around. But the post-CCT fellow that doesn't get the opportunities is in an area outside the control of the SAC. And if it's in this country, they will know people to talk to, but I can't give an answer on that.
Yeah, that's I understand. Zach, the one thing I would say is, I mean, I've sat on the consultant interview panel for our last kind of dozen or so appointments, and although you're perhaps not getting the clinical operating that and clinic experience that one would like on fellowship, it is an opportunity to work at some of the other things that will help you stand out on your CV. So there are lots of distance learning things that you can do. You can get a PG cert in medical education. There are certain leadership qualifications and courses that you can do online. It's a great opportunity to do a service improvement project. All of a sudden, everyone is doing remote consultations, be it telephone or virtual, because we have to. And so there's an opportunity for you to do a service improvement project within a trust where you are to look at how one might optimize that, how one might gauge patient satisfaction, make sure that everything is appropriate. You may want to look at digital consent. You may want to look at improving patient information pre and post-op. So actually, I appreciate that you may not be able to clinically what you need, but I think there's a great opportunity to do other things that will really help you stand out on your CV. Because when you go for your consultant interview, the fact is everyone else who's being interviewed at the same time will have done a post-CCT spine fellowship. Invariably, they will have been hit by impacted by COVID exactly the same time. So the question is, what can you do in the other bits of your CV to really make you stand up and stand out? And what else can you offer? Because the fact is, it's a bit like when you apply for medical school. Everyone's kind of going to get the grades, and it really comes down to what else can you offer beyond that. And so there is an opportunity to do things there. I'm sorry, I spoke too much. Lisa?
My brother gave me some good advice right at the start of this and said that what we need to be able to do, no matter who we are, no matter what we're doing, is be able to, at the end of all this, or towards the end of all this, to be able to look back with some pride and say, this is what I did with the time. If you think about being appointed as a consultant, as Cash says, people don't generally appoint amazingly brilliant pairs of hands. They appoint somebody that they want to work with, who is easy to work with, who makes a contribution. So looking for ways of making a contribution, looking for ways of turning this period around, making lemonade out of lemons, if you like, is probably going to be the key. I'll have a bit more of a think about it, Zach, and you and I know each other, and I'm happy to talk it through with you over this next week, if it would be helpful, once I've had a chance to think.
That'd be great. We've got just some messages come through. Jürgen Mesner says that the fellowship in BC, British Columbia, Canada, they're restarting elective practice in May, and their fellowship starts in August and should go ahead as normal. And thank you for the heads up, Jürgen. He says basically do what I said, which is check in with your fellowship director and keep in close contact. Thank you. The other thing, just whilst we're here, well, we've got the comment, Usman Ahmed is one of the core training TPDs in West Midlands, and he's saying if people are looking for any opportunities, they can DM him on Twitter at orthopaedic Oz. So it's orthopaedic OZ, all one word. Thank you. We're almost there, guys. So personal care and well-being, I appreciate it. It's not an orthopedic thing to talk about, and it can be considered a little bit, it's not what we do, but it's vitally important.
Yeah, yeah, I saw a poster which had 5 key points that really resonated with me, and I'd just like to share that. So the first point was, you're not alone. So I think we can all understand that this is something that we haven't been through before, and everyone's a little bit scared and think it's okay. So just acknowledging that. The second thing is kindness will get us through. So just things like smiling make a huge difference. 3, embrace the challenge. There's always something new that we can learn from this. 4, look after yourself. 5, you're stronger than you think, and we can get through this. So tips, I think we've got to be kind to ourselves. Just remember the basics. Eat well, stay hydrated, get exercise, rest and sleep. And then there are a lot of resources available. So some have been made free for the NHS. So the Headspace app, the Calm and the Unmind app. And the Royal College of Surgeons of England have got an excellent facility. So 24 hours, 7 days a week, they've got counsellors available, which you can access via a number which is on the website. So there's always someone that we can talk to. And then HE have got a really good debriefing poster, which just kind of like a little checklist. At the end of the shift, you can just check in and make sure that you're okay and your colleagues are okay. I think it's all about looking after yourself and looking after your colleagues to make sure we get through this together.
Thank you. So I'm just typing a response to someone because something's been done. The one thing I want to say as well is that we have an article going onto the OrthoHub webinar page today after this webinar finishes with links to wellbeing and personal care resources with a little article, but there'll also be links to the Calm, Unmind, Headspace, all the things that Trish has mentioned. And people really do take a lot of things for granted. But the fact is, eating, sleeping, drinking, hydration, checking in with people, even if it's ringing someone, FaceTiming them, Zooming people, all these things, we've been deprived of a lot of human contact, and it will affect different people differently. And it's absolutely fine to not be okay, as long as you then speak to someone. And so I think that's all very helpful stuff. So thank you, Trish. Lisa, did you want to say anything here?
I think Trish has put that all really well. Look after yourselves and look after each other.
Yeah, and I think that's one thing. And as a community, as an orthopedic community, it's really important that we look after each other, because there's a lot of significant life events happening at the moment. So the last thing we're going to just talk about is making the most of the learning opportunities. I think we've probably discussed that, to be honest with you, by now. And so Lisa's very kindly recorded a screencast for us that exactly talks about how to make the most of this. And so we will link that as well on the webinar page on the Author Hub website today. Okay. And then just to figure out, before let me just get it before we go and finish up. Let me have a quick look at the Q&A. So Zach thought we've answered. I'm just typing an answer to there. Neil Kang says, well said, Lisa. Beth said, shouting it at the top of your voice with a hammer. Thank you. And Naz Sagasi, a lot of questions the same. No, the same for name Chad just asked. The fact is, the final numbers that you need for indicative numbers CCT, they will stay the same. And we're going to have to work out how you go about achieving that. We did mention that earlier, so please do have a listen to the, it'll be on YouTube as soon as this finishes, so play it back and have a listen. Guys, before I just wrap things up here with regards to the panel, is there anything you guys want to say before we wrap up?
Yeah, quickly, if I could, Cash. I promised Stevie Softwaring I'd mention this in relation to the exam. Traditionally, there are quite a few no-shows, particularly in the November diet, and it's absolutely vital that trainees don't apply to sit the exam unless they think they're ready. And number two, if they've got a place at the exam, please turn up, because that is going to be the best way that we can accommodate the backlog next year.
And this comes very much to looking after each other. It is really quite astonishing that the amount of no-shows on the day who don't turn up for the exam, and that leaves, and there's a whole host of your colleagues who can't get a slot, and that pinch point is more focal now than ever. So it is absolutely vital that, and for some TPDs, it becomes a professionalism issue. And so if you've signed up, taken a slot of the exam, unless there's an emergency, turn up. Thanks, Rob. Guys, just regards to we figured we'd make the most of the lockdown, and in fact, we've got a literally captive audience. So we've got 2 more webinars in the next 2 weeks. Next week, we're gonna do the second part of last week's one, which is what to do with all the injuries that we've managed conservatively when they come back. There may be delayed non-union or infection, maybe the first delayed presentation of trauma. I really think there's a huge hidden disease burden at home, looking by the footfall in A&E and minors. We need to be ready for that. So we've got a fantastic all-star. Well, actually, we've got a couple of good speakers and Bates there next week, and that'd be really good. So we're going to be talking about how do you manage these non-union, malunion, infection, deformity. And then the week after that, we've really got a stellar lineup. We've got Dan Perry, Xavier Griffin, and one other talking about orthopedic research. And Pete wants me to put a tagline underneath that basically says, I promise you this will not be boring, or your money back. So we'll see how that goes. I want to finish just by thanking our panel. In particular, Rob. Rob has really had, I mean this independently, he's had an absolute baptism of fire. He could not have taken over that baton at any more difficult time, and he's worked really hard on our behalf. I'm very grateful to you. Thank you, Lisa and Tricia, for all you're doing representing the trainees and keeping everyone supported. And I want to thank everyone for making the time.